Good morning, good afternoon, and good evening. My name is Heather Chalmers, and I'm the President and CEO for GE Canada. It's a pleasure to have you on the call today. My understanding is that we had over 350 registrants for today's call, so it clearly speaks to the importance of cardiac imaging and MR, and thank you very much for joining. On a personal note, I want to take a moment to thank McGill. For those of you who may not know, McGill and GE Healthcare in Canada have had a very long-standing relationship. You'll hear from Dr. Friedrich today on the new focus specifically on cardiac MR, but whether it's them being a show site for us or the work that we're currently doing on artificial intelligence and advancing digital in imaging, we just really enjoyed working with you, and we hope this is just the beginning of a very, very long working and prosperous relationship together. And finally, good relationships start with terrific leaders. And on that note, I did want to call out Dr. Friedrich for the work that you've done. I was just mentioning before the call, it's been a long time since we saw each other in Waukesha and talked about the art of the possible. And it's through your leadership, your perseverance, and your fortitude that we are where we are today. So thank you for that. And without further ado, I'd like to introduce Jeju, our global MR leader for GE Healthcare.
Thanks very much, Heather. And so good morning, good afternoon, good evening. I'm Jay Xu. I lead the global MR business for GE Healthcare. Very nice to meet every one of you. We have two distinguished speakers today at our Cigna Masters event for cardiac and MR. And Dr. Friedrich actually goes all the way back with GE when we initially had our cardiac MR initiative back in the late 90s. So we've really come to a full circle to have Dr. Friedrich back and working our latest and the greatest technology today. And really welcome McGill University to the Cigna MR family. And on that, I was just talking to Dr. Friedrich earlier that there is a recent release of the completely revised 2020 version of the SCMR position paper on clinical indications of cardiovascular MR, and that started when Dr. Friedrich was the chairman of SCMR in 2018, and it took tremendous amount of work. And there'll be more of the position papers coming out. So a lot of big focus on cardiac MR, and I thank you for his leadership in getting us all these highly valued position papers for the industry. In 2012, GMR has made cardiac one of our business priorities, and we have made significant product improvements since then. Cardiac continued to be an important part of our MR clinical area, and we continue to collaborate with our leading luminaries and collaborators in making advancement in this space. Also together, for the other speaker today is Dr. Winseft with Weill Cornell Medical Medicine. And so we have had a long-standing research collaboration with Cornell and Dr. Winseft. and he is leading the excellent CMR research programs on multiple MR systems. Most recently, we installed our Air Recon DL technology, which is an AI deep learning based artificial intelligence image reconstruction technology on their scanners. And so Dr. Weinsafter really has the personal experience with our latest technology that's AI based that coming onto our entire portfolio. So really look forward to see how that's going to bring benefits to cardiac MR. So without further, I'm going to turn this over to Anya and talk a little bit about the GE Healthcare's focus in cardiac MR research.
Hello, my name is Anya Brau, and I lead our MR collaboration and development team for GE. And I want to start by acknowledging how thrilled we are to be partnering with McGill and with Dr. Matthias Friedrich on the pursuit of cardiac MR research and advancing this important imaging technology, and that they've chosen the 3T Premier GE platform as the scanner development platform for that work. And the work that we are excited to partner with them, to be partnered with them, is in pursuit of the vision of a 10-minute cardiac MR exam. And this is not something incremental, baby steps. This is a real leap forward in synthesizing technologies together to make easy, efficient workflows that are easy for the operator, easy for the patient, and make it accessible, this amazing sensitive imaging technology accessible to many more patients around the world, which is our goal. And building together these efficient workflows fits very well into our broader vision at GEMR of building an intelligent scanner where the highest quality imaging tailored can be performed in the shortest time and made accessible to many. So we're really delighted about this opportunity, and you'll hear more about some of the exciting results coming out of this partnership. And second, I wanted to acknowledge our partnership with Circle Cardiovascular Imaging, and together between McGill and Circle and GE, we've really been able to accelerate how the end-to-end solutions for cardiac MR can come together, including the post-processing and visualization side. And you'll hear more about the post-processing side of things from Mitchell Menavoy from Circle in the second webinar a little later on. So with that, thank you so much for attending. I'm going to turn it over to Andrew Korstein, who is our cardiac MR research scientist, working closely with McGill to give you a lab tour, since unfortunately none of us can be there in person today. Over to you, Andrew.
Tanya. You know, when our new Premier arrived about a year ago, it came by way of a flatbed truck. Now, as a new scientist working in the cardiac applications team and embedded within the research group at McGill, it was really interesting to see this flagship 3T system being hoisted up in the air and watching it slide into its second floor bay. Unsurprisingly, the arrival of a cutting-edge new MR generated a lot of buzz from the local media, including the largest French and English newspapers, La Presse and the Montreal Gazette. Now, seeing the scan room evolve from basically a construction site to its present state-of-the-art form, including a window view of the city, was really a great experience. Now, admittedly, in this photo, you're seeing the Montreal skyline in November, so the view might be a little bit gray, but at least we do have these roof panels to help us remember what the summer is like. More importantly than the scan room, though, is the system itself, which, in addition to the amazing hardware and engineering, comes with these fantastic air coils, which are lightweight, flexible, and easy to place. They've been a subtle but important part of GE's collaboration with McGill on the development of a 10-minute protocol. Even saving a minute or two during patient setup makes for a faster, more efficient scan, and really that's what our partnership has been all about. McGill's been an amazing group to work with, and they've helped us develop and test new sequences like DL-Cine, quantitative perfusion, and to analyze these with our Circle CVI workstations. More to the point though, McGill is leading the way in developing a comprehensive 10-minute CMR protocol based on myocardial function and tissue characterization. Now, instead of adding more and more scans to an exam, they've chosen an objective, disciplined route. You know, in a standardized, streamlined 10-minute exam, you could meet the needs of 70% or more of the cardiac patients without a contrast injection. And getting that rapid throughput improves hospital billing, the profitability of each scanner, in addition to the, making cardiac MR more available to the average patient. Now, I don't want to give away the ending of Matthias's talk, but this kind of focus on essentials is one of the best ways we can help move MRI towards something that's a bit more like this than what we have right now. Anyway, I won't delay the start of the symposium any further. So with that, I'll hand off to Martin Yannick, who will introduce our first speaker.
Hello, I'm Martin Janich. I lead research and development for cardiac MRI applications for GE Healthcare. I want to remind you that this is session 1 of 3 sessions, so we will have another one in next week and in 3 weeks from now. You do have the opportunity to ask questions, and we will have a Q&A session after each presentation. You will find the Q&A panel behind the button with the question mark. Please use it, and please rate the questions that were already posed so that we will address the most important questions at the end of each presentation. Now it is my pleasure to introduce the first speakers of our luminary speakers. That is Dr. Matthias Friedrich, Professor of Medicine at McGill University in Montreal, where he is the Chief of Cardiovascular Imaging. He is a fellow and master of the SCMR and also the past president of the SCMR. For many, many years, he has been part of the writing committee for consensus papers on the clinical use of cardiac MRI in multiple cardiovascular scientific societies. He has more than 210 peer-reviewed papers, and it's really my great pleasure to listen to his talk, and he will talk about the state of cardiac MRI in 2020. Matthias, you may be muted still.
Oh yeah, the famous mute button.
Right.
So you can hear me now well, and you can see my screen?
Yes, great. Thank you.
Okay, so thank you very much for the invitation and for the opportunity to present at the Signa Master Series. So what I will do during the next 20-25 minutes is to give you a rapid, and it has to be a rapid tour because there is so much going on in cardiac MR, on what I think is the current state of cardiac MR, but also the future. Anya and Andrew and also Martin have already referred to some extent to that. We're working together on a common future. And before I get started, I also want to acknowledge that I'm involved in software development, have research agreements, and receive research funding from several organizations. Now, I don't want to steal the end of my talk already, but I want to already state that MR, it's difficult to say what MR cannot do. It's much easier to say, of course, what MR can do, but it would take too long. So I'll just, in brief, there is not much, except for measuring pressure, there's not much MR could not do. Cine images, which previously took a lot of time, can give very detailed anatomical information, morphology, but also function, volume. Then we have flow quantification as a tool to quantify flow on actually a standard of reference level. Angiography has been around for quite a while, typically contrast enhanced, but more and more non-contrast techniques become available. There is perfusion, which is basically dynamic assessment of the inflow of blood and especially contrast agent into the myocardium. And maybe the most unique to cardiovascular MR, it's tissue characterization, where we can visualize tissue characteristics such as edema, or scarring. So I think it's needless to say that MR is by far, and I'm saying by far, the most versatile cardiovascular imaging modality. So contributions, I want to just read, are important to keep in mind. It's the gold standard for any quantitative assessment of the heart, including volumes, function, stroke volume, mass, etc. The only modality that gives that level of information for tissue characteristics, including infiltration and iron accumulation. Perfusion I mentioned already. And then what I will also address today, I think are nothing evolution in MRI in general, but with a specific impact on cardiac applications. Now, cardiac MR is not only versatile, but also comes with a very consistent image quality. So in a study, and that's already quite some years ago, where the image quality was maybe not as high as it is today, only 1% of the MR scans were deemed non-diagnostic. Compare this to other studies where we often have 10, 15, sometimes 20% of the images that are not diagnostic. And MR is used, or has been used since many years for congenital heart disease, so using angiography, but also flow studies. So you can see one of the tricks you can give. So this is the right atrium here, and this here you see the left atrium. Both are the same, is the same region. And in both you see a kind of a black stripe here, which is a saturation pulse that has been placed. And you can see, because we basically generate contrast agent in the right atrium, in the left atrium, and you see the jet from the right, from the left to the right atrium. If we place the saturation set in the left atrium, you see the black jet, and if you place the saturation in the right atrium, you see a white jet coming in. So this just as an example how you can use dynamic cine images for more than just quantifying. And then also similarly, it can be used for valvular heart disease. You can be, like here, severe aortic valve stenosis, you can measure valve areas, but you can also do flow velocity in a color-coded fashion and quantify that. So for valvular disease, especially over the most recent 2-3 years, it has become increasingly clear that even in valvular disease, CMR should be considered the gold standard and be a reference even for echocardiography. But it's not all that great for MR. There are also challenges that are still considered by many, are that it's complicated, it's expensive, there's a complex set of knowledge and technology required, and especially it's too time consuming. So we have to change that, because having such a great technology just being hampered by basically operational issues, that cannot be what we accept for long term. So MR has to be simplified. When we talk about simplifying MR, we have to talk about, okay, what do we actually need? And Andrew mentioned that already in about 70 to 80% of the cases, it's just about these three issues. We want to know about function, about tissue, and as a special vascular function, because in coronary artery disease, vascular function in the coronary arteries plays a huge role. That could be coronary artery stenosis, but could also be microvascular dysfunction. So if we look at these three and look at what we currently have and what is happening, so if we look at function first, we have the cine views. We can do that. I do a lot in long axis views, but most people are also used to short axis stacks. You see a lot of anatomy, like a small pericardial effusion. You see the valves. You can even see coronary arteries. You see papillary muscles and all that. And this can be now done much faster than before. But these images allow actually to extract even more information beyond just the volumetry. And this is strain. So this is a color-coded map of strain over time. So the colors here indicate the deformation of each of these pixels in space. And that allows even a less experienced reader to immediately see what is abnormal and what not. Now comes the interesting part. When I started doing MR in the last millennium, each of these cine loops would have taken me about 8 minutes to acquire. But all that for the entire ventricle can be done now within less than 5 minutes. And we have recently used technique by GE and are currently applying that in clinical studies that help improve image quality. So here is a standard cine MR in a patient with mitral valve replacement. You see there's an ugly artifact that also reduces the contrast to noise or the contrast between blood and myocardium. And here you see a technique called KT-ARC, basically a compressed sensing technique, but not just alone, but using deep learning algorithms that are basically embedded in some with a scanner to then remove all the noise. And here you can see the contrast between blood and the myocardium is much easier, so it's easier to quantify. And so far, our experience for that has been fantastic, and the acquisition is very fast, so we can do the entire left ventricle within a few breath holds instead of waiting 10, 15 minutes. Here's another example. A 4-chamber view, patient with atrial fibrillation, usually giving blurry edges, and again, the deep learning algorithm combined with a fast imaging allows for a very nice image that is much easier to quantify by eye, but also by the automatic algorithms of software. Let's move on to tissue. Tissue, as I said, is a unique capability of MR. And here's an example of a reperfused infarct where you see a pretty large area of high signal intensity in the water-sensitive image indicating edema. That's the entire territory of the left anterior descending or LAD coronary artery. And because it's a reperfused MI, not all of that tissue that had been affected is dead, but only this part, as indicated by the so-called late gadolinium enhancement image. And you can see the difference between the two is all the salvaged myocardium. This is the computer-aided evaluation. So this is a very unique capability of MR, in this case using water-sensitive images that do not need contrast agents and a contrast enhanced image. But of course, time is moving on. And while MR has been very helpful in identifying infarcts here, you see subendocardial infarct with an ischemic or etiology, and here patient with myocarditis where you have predominantly subepicardial and intramyocardial involvement. And in fact, this information on scar and normal tissue is extremely important and gives a lot of information beyond morphology and function. And here's an example. So this is a young patient with myocarditis, came into the hospital, echo was performed, echo said the function is normal, and the referring doctors were of course sent to say, okay, so there can't be much wrong, but the blood values indicated a more extensive injury. So the MR indeed showed that there is, despite the pretty normal overall function, that there is extensive necrosis in this patient, in this young patient, that is of course compensated by the normal myocardium. So this is just to say how important tissue characterization is. But as I said, time moves on. These techniques have been based on signal intensities, and signal intensities are of course dependent on all the sequence settings, but also on windowing and all that. So that's why has been already almost 20 years ago that we proposed in the first clinical study T1 mapping. And what T1 mapping does, and I don't have the time to go into the physics, but it moves away from looking at signal intensity, but goes to the core magnetic property of the tissue, which is the relaxation time. And there are two times, there's T1 and T2, and to measure that itself or actually estimate it. And what we saw is that after contrast agent, the contrast administration, the contrast accumulates in the infarct, so the T1 drops. But I think even more interesting was that even before we gave the contrast agent, the T1 was already different in the infarct being higher. So T1 was higher, and the reason for that simply was that acute infarct is associated with edema, edema has water. Protons in water take much longer to relax, so T1 is longer. So it was pretty easy, could be easily explained. So that was in 2003. Now fast forward, now we are at a stage where we can use T1 to look at fat, water, extracellular volume, and iron, and even come up with certain. So this is the T1, and this is the extracellular volume, which you can calculate from pre and post contrast T1 maps. And with this, you can differentiate, for example, fatty infiltrations such as in Fabry's and iron, where you have a decreased T1 from acute MI, so acute injury, and especially amyloidosis, with a high T1 and a high extracellular volume. So mapping gives a hard number, and while numbers differ between scanners, there are efforts now to standardize that, for example, using Z-scores, so that we can talk between different scanners, so that we have clear cutoff values, quantitative, continuous variables that can be used to differentiate diseases. But even here, time doesn't stop, and T1 and T2 mapping could be analyzed together. And this is one of the recent works of Ria Garg from our team here, that if you perform a combined analysis of T1 and T2, you can actually increase your diagnostic accuracy as defined or as shown here by the area under the curve for detecting patients with ischemic cardiomyopathy. So combining these values, and then you can even go one step further. So instead of acquiring T1 maps and T2 maps separately and individually, there's a new technology out there. Actually, in this technology, the idea started with fingerprinting, but now there are several groups working on several solutions, and I just want to highlight one of them. This is the one we are currently working a lot with. It's not the only one we're working with, but this one has been in our focus recently. It's called multitasking. So what does multitasking do? In short, instead of prospectively planning the sequences, the settings on the scanner to acquire a T1 map, a T2 map, a cine, or what have you, what this technique basically does, it provides a kind of, although I don't like the term, but it basically illustrates it best, a kind of a shotgun approach. So basically acquire seemingly randomly noise signal over time, and then let a computer sort out, okay, what does this all mean if the noise from that pixel looks like this, and if I try to figure out all this noise, the signals coming back from there, in which kind of patterns do they fit? I can basically then calculate, okay, the T1 of that pixel has to be X, and the T2 has to be Y, and the signal intensity in a cine image would be this. So later on, so basically do stuff first and then think. It's usually not what we should do in life, but in this case, it helps a lot because you can have basically a relatively simple algorithm for acquiring the data. These are actually not very difficult sequences. And we use a stack of star sequence, and I want to thank here Andrew Korstein for doing this great work, implementing that. We're working together with Cedars-Sinai in Los Angeles, and I want to highlight the work of Anthony Christodoulou, and also Circle Cardiovascular Imaging with Mitchell Benovoy, to create this system where you acquire the data, you automatically import the data, and then you reconstruct these images, and then you visualize and report them. So with this technique, you get stuff like this, which doesn't even look like a heart or anything else, but this is what the technologist sees. But then the computer interprets these data and then generates maps, T1 maps and T2 maps, and cine, and other techniques also, for example, allow for coronary angiographies with a very high spatial resolution. So I think this is the new generation of MR imaging. And especially for cardiac, that is very helpful because you do not need a trigger, you do not need breathing maneuvers. It all can be with using complex algorithms deep learning based algorithms to sort this all out. And this can be done in less than 15 and probably soon in less than 10 minutes of a total acquisition time. So this, I think, will lead to a complete and thorough paradigm shift in MR imaging, especially for cardiac. So the last one I want to mention is maybe the trickiest, because here it's about vascular function. It's not about morphology, it's not about tissue characteristics, but it's about something happening in a dynamic fashion. And vascular function here is defined as what do the coronaries do if they are exposed to certain stress, because a patient, when the patient has coronary artery disease and therefore has a reduced function or a blockage, and so certainly to stress, you cannot see this in a static image. You cannot even see that during a resting state of the patient in the scanner. So you have to somehow stress the patient. And this is usually done using perfusion imaging. Here's the case with a mild wall motion melt here. And if you look at the baseline, you see that they're pretty homogeneous. But if you look at the same scan now performed during adenosine, you can see that there's a pretty big pretty big perfusion deficit, consistent with a circumflex stenosis. And you could say, okay, maybe this is all dead, but the beauty of MR is you can also do a tissue characterization in the same scan, and you see it's just a very small infarct, the bright area here. So this is how it is traditionally done. And actually, this technique has made a huge entry into guideline level recommendations. One of the key studies that led to that was the MR Inform trial, where first pass perfusion imaging with a clinical visual analysis was compared to the currently accepted invasive gold standard of the fractional flow reserve. And you see that, and this is, I really like this study a lot because it is looking at outcome. It doesn't look at accuracy, prognosis, and whatever, because it doesn't really matter. What really matters is what's the impact of the use of this technology on outcome. So if I use CMR to figure out how to treat this patient and compare it to an invasive parameter, the FFR, and follow them based on these decisions, I can see here that the outcome is the very same. So in other words, it doesn't really matter whether I make my decision based on a non-invasive cardiac MR scan or on an invasive FFR. And this is remarkable by itself, but even further, when you look and read the paper carefully, the number of interventions actually was smaller in the cardiac MR group, which means you're not only having the same impact, but you achieve the same positive impact on a global level with less interventions. So this study was really the final blow for comparing this to nuclear. I think it's now abundantly clear that nuclear cardiology cannot keep up with that level of quality. And besides, it also uses radioactive agents. So I think in Europe that has already happened, but here in North America, I think it's time now to let go of nuclear cardiology and ask new cardiologists to move over and do cardiac MR. This is a personal opinion. I'm happy to discuss that anytime. But even perfusion imaging is now getting to the next level. And this is how we are starting now to use perfusion. The evaluation is now automated and quantitative. So I can actually, like with a PET scan, I can get to actually quantitative data. And this is work partially by Mitchell Benovoy. And currently there's an international expert group of GE users that validates that in various clinical settings. Okay, I have just 1 minute left for or 2 minutes left for the last thing. It's basically an outlook in how MR may do that in the future, vascular function imaging. So what we have, what we could show that a very well-known physiologic mechanism of our coronary vasculature is that if you perform hyperventilation, it goes into vasoconstriction. If you hold your breath, it goes into vasodilation. This leads to changes of the carbon dioxide, the blood volume, the oxygenation, but also T2 and T2 star via the so-called Bold effect. Now, the response to these maneuvers, of course, depends on the function. So if the function is impaired in certain regions, for example, because there's a coronary artery stenosis, then in this region, there will be no vasoconstriction because the heart just can't afford to go into vasoconstriction. Local factors like acidosis will prevent that. And it can especially also not go into vasodilation during a breath hold. And after having gone through a lot of validation studies in animal studies, preclinical studies, and clinical studies, here's just the last one of them from Bern now, so from another group that could show that compared to healthy people, a breath hold does not lead to the increase of blood flow and then to an increase of the oxygenation as in the healthy people. It does that in the remote territory of patients with coronary artery disease, but in stenotic territories, you can see that this does not happen. There is no vasodilation. It's basically staying flat, and in people with global vascular dysfunction, it even goes down. So think about it. This is a test that requires a breathing maneuver and a bolt sensitive imaging sequence that doesn't require any contrast agents, no needles, no treadmills, no hand grips, whatever, just a very quick test. And now I'm going to show you something that not many people have seen. It's basically hot out of the labs. This is a collaboration between McGill, GE, and Circle Labs. What you see here is basically the cine image where the color of the myocardium reflects the oxygenation. And on the right side, you see the scale. So you can basically see that in certain areas it remains red, which is basically a mild deoxygenation in certain areas. But in some areas, and here you can see especially here, it stays black quite often during this contraction relaxation cycle. And this map is an oxygenation map normalized to the right ventricle, so to deoxygenated blood. So we have an internal normalization. So you can see that over the cardiac cycle, actually, there's a certain curve of oxygenation, deoxygenation that can be visualized and even semi-quantitatively be assessed, normalizing it to the right ventricle. And then here you can see easily that, especially during late systole and early diastole, you get the point where you have maximum extraction of oxygenation, and this is where the heart here gets into repeated little episodes of ischemia. So I think this is how MR will look like in the future. We will have standardized multi-parametric, multi-contrast sequences and evaluation algorithms such as multitasking, or others are fingerprinting, free-running framework, and a technique from King's College. And we will have simple maneuvers like this where we can assess vascular function. And with that, I want to thank my team, which is fantastic, for doing all this. We have postdocs, doctors from several countries working here. We have a collaboration between radiology and cardiology, and a fantastic team of technologists who are highly motivated. Without them and without everybody's input, this all would not have been possible. I also want to thank here for the collaboration with GE and the fantastic work of Andrew. With that, I want to give back the microphone. Thank you.
Thank you very much for this excellent presentation. You very nicely outlined that the technology is there to measure T1, T2 with multitasking at the same time. At the same time, you provide evidence how diagnostic confidence can be increased by combining T1 and T2. And there is one question about T1 mapping, post-contrast. Can you give us a small how do I do tutorial? What's your method of measuring T1 post-contrast and calculating extracellular volume maps?
Yeah. So in brief, you use a simple equation. You insert T1 pre and T1 post contrast, and you need a value for the hemoglobin. You can do this either from a blood test, or you can also use so-called synthetic hemoglobin derived from images, from MR images. The key point of ECV quantification or mapping, for that matter, is the time point for the post-contrast T1, because post-contrast T1 means it is acquired after injecting gadolinium. Gadolinium reaches a certain steady state, but this is of course not a stable steady state for a long period, so it has to be acquired ideally between 10 and 20 minutes after the injection, because thereafter there's a significant washout from most of the territories, and then your T1 again will change. But if you standardize that, the T1 post-contrast is, of course, necessary for ECV. I would not use T1 post-contrast values themselves. I would always look for the native and the ECV map that can be calculated from pre and post-contrast T1, because post-contrast T1 alone is too dependent on the other factors, especially the timing after the contrast injection.
Mm-hmm. Thank you. Also a question about access of cardiac MRI to all cardiac patients who need this examination. How do you envision to improve the access to a standardized and rapid CMR examination?
That is, of course, an extremely important question. Currently, access is limited by tradition, politics, and cost. Traditional radiologists own the scanners, cardiologists want to do cardiac MR. Radiologists do not want to have cardiologists play with their scanners. Cardiologists do not want to have radiologists talk too much into their physiology. So this is where collaboration is key. Most of the sites I know where collaboration works are successful. Many of the sites I know who do not collaborate are not successful in pushing that forward. So this is one side of it. The second important is the cost, and this is what I try to also address a little bit here. The costs associated with MR are costs that just the scanner itself even running idle, the scanner costs a lot of money. So the shorter we are with our scans, the more cost efficient we can be. If we take an hour or longer, we will not be cost efficient in the long run. So we have to get to shorter times, and that's why we have to have standardized short protocols. And the new techniques, which I actually, by the way, like to smart techniques, like because simultaneous multi-parametric acquisition and reconstruction techniques, so like multitasking, etc. These techniques will allow radiologists who do not have the vast experience like Sylvia and Maggie in our center to perform a scan, to acquire the data that are needed for reconstructing all the images we take. So it is it's fast, it's standardized, it doesn't necessarily have to be repeated. So it saves time, and by that it saves money. By saving money, it will enter clinical application, because the future of medicine has to be value-based. We cannot continue paying for whatever a doctor does. We have to pay for what this test or this procedure brings to this individual and also for the society. So the value-based medicine will require tests and treatments that are efficient, and MR is more efficient than any other imaging technology. That's why MR will play a really important role in that context.
Thank you, Matthias. So with this Q&A, I'd like to wrap up the first part. Thank you again for the presentation, Matthias. And now I'm thrilled to introduce the next speaker, Dr. Jonathan Weinsaft. Dr. Weinsaft is Professor of Medicine at Weill Cornell Medical College in New York City, where he is the director of the Cornell Cardiac MRI program and the principal investigator of the Advanced Cardiovascular Imaging Research Lab. He's also an associate member at the Memorial Sloan Kettering Cancer Center. He is a fellow of the ACC as well as the SCMR, and he contributed to multiple international cardiovascular societies. He has published more than 140 peer-reviewed papers. It's my pleasure to listen to his talk about cardiac MRI tissue characterization for the assessment of cardiac masses and remodeling.
Thank you very much. I just want to make sure, can everyone see my slides?
Not yet.
No. How do I share my slides, or screen save, or open share tray?
Yes. There we go.
Yes, there we go.
And
Great.
if you just, perfect.
Perfect.
Excellent.
Thank you very much. Thank you again for this invitation. Thank you, Matthias, for what's obviously an outstanding talk in terms of the future. As we've learned earlier, certainly CMR is many different potential tests within one exam and is rapidly expanding in terms of the information that it can provide. Certainly, as Dr. Friedrich has outlined in a clear and outstanding manner, the incremental utility of the test lies with respect to tissue characterization, namely the ability to demonstrate fibrosis, edema, infarction, and to pair that to functional perfusion and structural changes is what is unique. What I'm going to be outlining today are not only primary advances in terms of data demonstrated via tissue characterization, but the incremental utility that can be derived via post-processing. Certainly, we know not only can CMR provide valuable tissue characteristics in terms of underlying pathophysiology of myocardium, but that new techniques to post-process primary CMR data can yield new insights. We've increasingly used the AIR recon approach, which is a deep learning based algorithm, and this yields certainly higher spatial resolution, higher signal to noise ratio, and higher image delineation versus conventional imaging approaches. Here's a typical exam from our lab. We could provide many others. This is a 75-year-old woman with new onset chest pain, similar to Dr. Friedrich's examples in the Canadian setting. This woman had a normal echocardiogram. Despite that, as you can see here in terms of tissue characterization, we see very nice demonstration of myocardial infarction in the posterolateral wall. Function was also slightly abnormal in those territories, and that's complemented by parametric mapping that we would do. Obviously, with the deep learning approach, you can see outstanding delineation of the infarct, outstanding signal-to-noise ratio, and CNR as well. What I'm going to focus on in terms of data from our lab, in terms of new data yielded by our GE scanners, is the incremental utility of CMR tissue characterization, not only for myocardial tissue characterization, but for tissue characterization of cardiovascular masses, which are a major source of referral in our lab. We know, many of those in the audience know that tissue characterization of myocardium stems largely from focus of the late gadolinium enhancement and increasingly parametric mapping approaches. The differentiation of infarction versus non-infarcted viable myocardium stems from differential distribution of gadolinium. Increasingly, in work by Dr. Friedrich and others, we're able to differentiate those based on non-contrast approaches, which also alter myocardial tissue properties. What I'm going to focus on is the fact that thrombus, areas of non-vascular regions within the myocardium that can occur, also have differential parametric features as well as differential features on late gadolinium enhancement imaging. And I'm going to show you data from our lab using our GE scanner, demonstrating that provides important diagnostic and prognostic approaches. Much of what we do is focused on a new technique which we've developed and validated, looking at selective nulling of myocardial of thrombus within the heart. That stems from complete absence of contrast enhancement in those regions, which differ from regions of normal myocardium and areas of myocardial infarct. By bringing out that inversion time on post-contrast inversion recovery imaging, we can selectively null thrombus. Here's a conventional late gadolinium enhancement image. Here's what we would term, and many others term, a long inversion time late gadolinium enhancement sequence. So you can selectively null that thrombus and image it and delineate it in that way. In an initial proof of concept study, we validated technique in relation to histopathology, is shown in these examples here. So here we see a typical left ventricular apical thrombus, as well as mural thrombi adjacent to the anterior wall and inferior wall of the heart, all of which were concordant with pathology. In terms of new pathophysiologic insights, we demonstrated that that's strongly related to contractile function and differed based on etiology of cardiomyopathy. In a subsequent study at Weill Cornell, we compared late gadolinium enhancement imaging on GE 1.5 Tesla scanners to 3 separate approaches, all of which identify thrombus based on anatomic morphology or appearance. Here are representative examples. 2 patients with normal contrast enhanced echocardiography. Here's patient A. Also, the cine CMR was also unremarkable. But in terms of late gadolinium enhancement imaging, we can see a small mural thrombus in that area, which was demonstrated and validated based on at the time of surgical resection. Here's another example. This was also read as negative for thrombus on contrast enhanced echocardiography. We do see some area of swirling in the left ventricular apex, but on blinded core lab, this was read as normal. When we look at the cine CMR, again, we see some swirling, some increased signal in this area, but actually on the long inversion time imaging, the area in which we see thrombus was not in the left ventricular apex, but in the posterior wall of the LV, again demonstrating incremental utility of tissue characterization. We looked at diagnostic performance and showed that all 3 anatomic imaging techniques had poor diagnostic performance, impaired sensitivity versus late gadolinium enhancement imaging, with echo demonstrating that approximately 1/3 to 2/3 of all thrombi were missed in relation to tissue characterization. We've also shown that in the current era, this finding is very, very common despite prompt reperfusion. Does this matter? Absolutely. In several longitudinal studies, we've compared tissue characterization using long inversion times, conventional morphologic imaging, showing differences in terms of prognostic outcome, including embolic events and stroke, when patients were stratified based on LGE evidence thrombus as compared to anatomic imaging as performed by echocardiography. The bottom line was the tissue characterization evidence thrombus predicted stroke risk, whereas anatomic detection of thrombus was limited, with poor diagnostic sensitivity and specificity corresponding to suboptimal prognostic value. More recently, we've transitioned our lab and transitioned our lab's focus. And what I would say to the audience is that perspective is everything. This is New York City in better times. We're hoping to return to those times. This is the view from our lab. And this is the view increasingly in terms of our lab's focus. We span several hospitals in the greater New York City area in which we use our GE scanners. We've transitioned to a major academic focus at Memorial Sloan Kettering as well. And when we focus on cardiovascular tissue characterization and cardiovascular masses, the fundamental concept is not simply, is there a thrombus there or is there a thrombus not there, but what is the etiology of the mass and how can we differentiate it based on tissue characterization? I showed you this graphic in terms of the late gadolinium enhancement approach that we use. Typically, we've used this on both 1.5 and 3T scanners to identify thrombus. And we've transitioned this approach to not only characterize areas of thrombus, but to identify neoplasms in the heart. Whereas neoplasms, like thrombus, can vary in shape and size, they can intrinsically be identified based on presence of vascularity. Vascularity is necessary for tumors to grow, and that vascularity alters tissue-based appearance on CMR tissue characterization. Our approach also allows us to identify areas of vascularity and avascularity within masses. So here's a typical example. This is a 45-year-old woman with a mediastinal mass. We can see a large mediastinal mass encompassing the great vessels as shown here. And we can see on LGE, there are areas of contrast enhancement corresponding to vascularity within that mass mass and areas of black, non-vascular areas corresponding to areas of tissue necrosis, which were concordant with that seen on histopathology. This was an invasive sarcoma with prominent vascular supply in avascular areas. Using our scanners, GE 1.5 and 3T scanner, I performed a series of studies. We first looked at distribution of masses, cardiac neoplasms among stage 4 cancer patients, showing many of the conventional rules that we've been taught in terms of identification of these masses don't hold true. Many tumor etiologies not thought to go to the heart, such as pancreatic and CNS tumors, were often found to have cardiac involvement, and typical patterns that we've been taught, such as the necessity for pericardial or pleural effusions, didn't typically hold true. Here you see a representative enhancement.
Cardiology, I think that's great.
Here are some, here's a
interest in sort of informatics is related to, would that be fair, or?
Say leveraging digital health technologies to optimize cardiovascular health.
Hello? Here we see a representative example of that. I'm going to go back to my slideshow for a moment. I think I lost you. Here we see a representative example in a patient with new onset shortness of breath, and we can see an enhancing mass in the right ventricle, and incremental, and use that together with perfusion imaging, in which we can see impaired perfusion of the mass as well as impaired perfusion of the lung fields, which corresponded with pulmonary embolism diagnosed on CT. In a subsequent study in which we looked at prognosis, we demonstrated that differentiation of tumor and thrombus based on enhancement pattern was strongly prognostic. Here we see long-term outcomes in which we differentiated patients with thrombus, meaning non-enhancing masses as identified based on tissue characterization, versus neoplasms, meaning enhancing masses on tissue characterization, showing marked differences in terms of outcome. And we will look at conventional variables such as size, shape, or number. We lose that prognostic value. Here's a typical example of that. As a quiz question, which patient has a thrombus or a neoplasm? Very difficult to differentiate based on anatomic appearance alone. Both have right atrial masses, which look near identical. But when we look at tissue properties, very different. Diffusely enhancing mass. This was a metastatic neoplasm, pancreatic in etiology, whereas patient B has a non-enhancing mass. This is a thrombus that resolved with anticoagulation. In a subsequent study, we compared this to PET, again, thematically demonstrating the data that Dr. Friedrich has shown earlier, demonstrating incremental prognostic utility of LGE-CMR tissue characterization. These are 121 patients undergoing dedicated CMR tissue characterization and FDG PET. All of these patients had systemic cancer. When we look, in some cases, there was good concordance. Here we see a mass in the pulmonary outflow tract, shown here, enhancement on LGE tissue characterization, FDG uptake in those areas. But when we looked overall, we could see that PET in many cases was limited. Overall sensitivity was about 70%, accuracy 74%. And why did that occur? Because in many cases, as shown here, there was lack of FDG uptake despite enhancement within those regions. So here's a representative example on FDG PET shown on tissue characterization. This was a patient labeled with quote unquote new onset hypertrophic cardiomyopathy, in which we can see marked hyperenhancement in that region on pathology and metastatic neoplasm intramyocardial in location. What we demonstrate is that PET sensitivity and specificity varied in relation to avascularity of tissue characterization, tissue composition on LGE. When the tumor was highly vascular, as shown here on the left, a lot of contrast enhancement, it lit up on PET. Areas of contrast enhancement, we can see ring enhancement, correspondingly ring in FDG uptake. But in predominantly necrotic or avascular masses, avascular neoplasm or thrombi, that's where PET fell short, lack of FDG uptake. And we demonstrated that incremental utility of LGE-CMR impacted outcomes, as shown earlier. Again, increased FDG, increased contrast enhancement in the mass, very poor prognostic indicator. Where are we going in terms of future direction in our lab? Much like Dr. Friedrich, we are increasingly focused on quantitative perfusion as an area of focus in terms of characterization of tumor and tumor growth, T1 mapping as well. So here's a representative example of this 54-year-old man, adrenal carcinoma, again labeled with hypertrophic cardiomyopathy. But when we look at the differential perfusion in those areas, very, very unique perfusion, differential perfusion within that wall, consistent with a metastatic neoplasm, which was diagnosed on biopsy. In terms of T1 mapping, we're also increasingly using that as a means of not only identifying masses, but prognosticating in terms of outcomes. So here's a small mass in the interwall, looks central necrosis, and we can see and quantify the tissue properties of that based on pre and post contrast T1 mapping. Here's the patient on serial imaging. Here's the baseline T1 map pre and post contrast. And here's serial imaging over 4 years follow-up. And we're going to be publishing this data in terms of prognostic value of T1 mapping for this approach. Here's some representative abstract data that we published at SCMR on this. Finally, just in the interest of time, obviously for cancer and non-cancer populations, as touched upon by Dr. Friedrich, we're obviously using it not only for mass assessment, but for myocardial assessment as well. We've moved beyond the conventional notion of LGE imaging, increasingly using pre-contrast, which, as touched upon earlier, incredibly important and valuable in terms of characterization of patients with amyloid and cancer-associated cardiomyopathies, obviously, as well as post-contrast imaging as well. So in summary, and in interest of time, I think thematically we've learned that both that an array of CMR approaches enable integrated anatomic functional tissue characterization of cardiac masses, that both anatomic and functional imaging provide important data regarding physiologic sequelae of these masses. The key take-home point being that CMR evidence vascular, namely contrast enhancement or lack thereof, can differentiate neoplasm versus thrombus, and importantly, stratifying prognosis, and that CMR tissue characterization adds to diagnostic assessment. I'd like to thank everyone, certainly in our lab, as well as GE, for inviting me to speak today at this important symposium. Thank you.
Thank you, Dr. Weinsaft, for this very comprehensive talk and showing us all the already published evidence. There is a question about quantification. For quantification of thrombus, do you see value in quantifying the volume of a thrombus as opposed to qualitative assessment?
Well, I think that certainly that's important in terms of assessing thrombus response to anticoagulation, having an assessment of baseline thrombus size is important and may be of importance in terms of embolic risk. That being said, when we've looked at thrombus size, thrombus distribution, other anatomic features in terms of stroke risk, those really generally fall out in terms of multivariate analysis. So certainly it's clinically important, it's relevant to our clinicians, but its prognostic value, I would say, is likely less than that of tissue properties of the thrombus itself.
Mm-hmm. Okay. And also a question about extracellular volume mapping. For differentiating neoplasm and thrombus, do you see value of extracellular volume mapping as opposed to LGE imaging?
Absolutely, absolutely. So that was data. Let me give credit to Angel Chan, who's a member of our lab, and it presented this data last year at SCMR, and we're going to be submitting this imminently to one of the major journals. Absolutely. Our data, both in terms of non-contrast as well as contrast-enhanced T1 mapping, does demonstrate ability to differentiate between neoplasm and thrombus. What we are particularly interested in is whether extent of contrast enhancement on quantitative parametric mapping provides additive prognostic value. But certainly what we do know now is that the ability to differentiate is there. What we're working on with several other labs and hope to do in a multidisciplinary manner is demonstrating diagnostic cutoffs, which are robust. I think, as Dr. Friedrich alluded to, that's where the field needs to go, whether it be Z-scores or otherwise broadly utilizable cutoffs that can be applied readily in clinical practice.
Thank you. And could you also comment on non-gadolinium approaches, maybe 4D flow?
Absolutely. So we're, as alluded to earlier, we're looking at the utility of non-gadolinium enhanced non-contrast T1 mapping for differentiation of tumor versus thrombus. And that data has been presented and is being prepared for publication. There are a number of groups, University of Wisconsin, which is a major GE site, as well as European groups, as is our own lab, looking at four-dimensional flow as a predictor of thrombus formation, as well as thrombus resolution. So we published with Oliver Wieben at the University of Wisconsin, utilizing four-dimensional flow imaging as in relation to formation of left ventricular thrombus. Others have looked at flow stasis within the left ventricle as a marker of thrombus response to anticoagulation, which is certainly a very exciting field.
Mm-hmm. Thank you, and I want to thank you again for preparing and presenting this excellent talk, and also want to thank you, Dr. Friedrich, again for the first talk in this session. So let's wrap up session 1. I'd like to remind everyone that this is session 1 of a series of 3 webinars that we are holding. The second one will be on November 24th and the final one on December 8th. And I invite you to join the other 2 as well. And I hope you will be able to join. I'm thanking again our speakers. And I thank you so much for attending. See you soon. Bye-bye.